This week's lecture is on schizophrenia. Schizophrenia is a disorder characterized by disturbances in thought, emotion, and behavior. Disordered thinking, in which ideas are not logically related, faulty perception and attention, a lack of emotional expressiveness, or at times inappropriate expressions, and disturbances in movement and behavior, which could include a disheveled appearance, are examples of some of the symptoms of schizophrenia. The lifetime prevalence of schizophrenia is slightly less than 1%, and it affects men slightly more than women. Schizophrenia is diagnosed most frequently among some groups such as African Americans, though it remains unclear whether this reflects an actual difference among groups or bias among clinicians. Schizophrenia sometimes begins in childhood, but it usually appears in late adolescence or early adulthood, and usually somewhat earlier in men than in women. People with schizophrenia typically have a number of acute episodes of their symptoms and less severe but still debilitating symptoms between episodes. The range of symptoms in the diagnosis of schizophrenia is extensive. Although people with schizophrenia typically have only some of these problems at any given time, no single essential symptom must be present for a diagnosis of schizophrenia. Thus, people with schizophrenia can differ from one another quite a bit. About 30 years ago, researchers divided symptoms into two domains called positive and negative. Subsequently, the original domain of positive symptoms was divided into two: positive, which includes hallucinations and delusions, and disorganized speech and behavior. The distinction among positive, negative, and disorganized symptoms has been very useful in research on etiology and treatment of schizophrenia. On the right-hand side of this slide are the DSM-5 criteria for a diagnosis of schizophrenia. And in order to receive a diagnosis of schizophrenia, an individual must display two or more of the following symptoms for at least 1 month. One of these symptoms should be either 1, 2, or 3. The symptoms are delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, negative symptoms such as a diminished motivation or emotional expression, and decline functioning in work, relationships, or self-care. To receive a diagnosis of schizophrenia, an individual must display signs of disorder for at least 6 months, or if during a prodromal or residual phase, negative symptoms, or 2 or more of symptoms 1 through 4 in less severe form. For the most part, acute episodes of schizophrenia are characterized by positive symptoms. One type of positive symptom is delusions. Delusions are beliefs, contrary to reality, and are firmly held in spite of disconfirming evidence. Delusions may take several forms. Persecutory delusions are the belief that someone is out to get you. Thought insertion is the belief that thoughts have been placed in one's mind by an external source. Thought broadcasting is the belief that one's thoughts are being broadcast or transmitted so that others know what one is thinking. A person may believe that their feelings or behaviors are being controlled by an external force. Grandiose delusions are an exaggerated sense of importance, power, knowledge, or identity. Ideas of reference involve the incorporation of insignificant events within a delusional framework and assigning these unimportant events personal significance. Delusions are found among more than half of people with schizophrenia, but are also found among people with other diagnoses, including bipolar disorder, depression with psychotic features, and delusional disorder. The most dramatic distortions of perception experienced by individuals with schizophrenia are hallucinations. Hallucinations are sensory experiences in the absence of any relevant stimulation from the environment. Auditory hallucinations are more common than visual hallucinations. 74% of one sample of people with schizophrenia reported having auditory hallucinations. Auditory hallucinations might take the form of perceiving one's own thoughts spoken by another voice. Others experience hearing voices arguing or commenting on their behavior. Many people with schizophrenia experience their hallucinations as frightening or annoying. However, some individuals experience their hallucinations in a more pleasant way, particularly if they believe, for example, that the voice is a known and liked person. Some theorists propose that people who have auditory hallucinations misattribute their own voice as being someone else's voice. Neuroimaging studies have shown greater activity in Broca's area, the productive language area of the brain, when individuals with schizophrenia report hearing voices. Misattribution of voices may result from a problem with the connection between the frontal lobe areas of the brain that enable speech production and the temporal lobe areas that enable speech understanding. Negative symptoms of schizophrenia consist of behavioral deficits which include avolition, asociality, anhedonia, blunted affect, and alogia. Negative symptoms tend to endure beyond an acute episode and have profound effects on the lives of people with schizophrenia. The presence of negative symptoms is a strong predictor of poor quality of life, as measured by occupational impairments and number of friends 2 years following hospitalization. Avolition is apathy or a lack of motivation and seeming absence of interest in or ability to persist in what are usually routine activities. Asociality is severe impairment in social relationships. Anhedonia is a loss of interest or a reported lessening of pleasure. There are two types of pleasure experiences: consumatory pleasure and anticipatory pleasure. Consumatory pleasure refers to the amount of pleasure experienced in the moment or in the presence of something pleasurable. Anticipatory pleasure refers to the amount of expected or anticipated pleasure from future events. People with schizophrenia show a loss of anticipatory pleasure, but not consumatory pleasure. Blunted affect refers to the lack of outward expression of emotion. This may take the appearance of vacant stares, motionless facial muscles, and lifeless eyes. When spoken to, the person may answer in a flat and toneless voice and not look at their conversational partner. This blunted affect refers to the outward expression of emotion. People with schizophrenia report experiencing as much or more emotion internally than people without schizophrenia. Alogia refers to the significant reduction in the amount of speech. Taken together, these negative symptoms can be divided into two domains: experience and expression. Also known as formal thought disorder, disorganized speech refers to problems in organizing ideas and in speaking so the listener can understand. Speech can also be disorganized by what are called loose associations or derailment. In the case of loose associations and derailment, the individual may be more successful at communicating but has difficulty sticking to one topic. Disorganized speech is associated with problems in executive functioning, not language production as one might expect. Executive functions include problem-solving, planning, and making associations between thinking and feeling. Disorganized speech is also associated with the ability to perceive semantic information, such as the meaning of words. Disorganized behavior takes many forms, including inexplicable bouts of agitation, unusual dress, childlike or silly behavior, food hoarding, and collecting of garbage. All of these represent a loss in the ability to organize one's behavior. One other symptom of schizophrenia that does not fit within the positive or negative symptoms we have already discussed is abnormal psychomotor behavior. Catatonia is the prime example of this symptom. People with catatonia may gesture repeatedly, sometimes using complex hand and arm movements. Some people experience an increase in activity level, including flailing of limbs. At the other end of the catatonic spectrum is catatonic immobility, which involves maintaining an unusual posture for an extended period of time. Catatonia is seldom seen today. This could be because of more effective medications or misdiagnosis in previous years. Schizophrenia is part of the DSM-5 chapter entitled Schizophrenia and Other Psychotic Disorders. There are a number of other disorders in this group which are provided in the table on this slide from the Kring et al. Text. These include schizoaffective disorder, delusional disorder, schizophreniform disorder, and brief psychotic disorder. Two brief psychotic disorders are schizophreniform disorder and brief psychotic disorder. The symptoms of schizophreniform disorder are the same as those of schizophrenia, but last only from 1 to 6 months. Brief psychotic disorder lasts from 1 day to 1 month and is often brought on by extreme stress. Schizoaffective disorder comprises a mixture of symptoms of schizophrenia and mood disorders. The diagnosis requires either a depressive or a manic episode. With regard to genetics, schizophrenia is genetically heterogeneous. That is, genetic factors may vary from case to case, mirroring the fact that schizophrenia, as discussed earlier, is symptomatically heterogeneous. It is important to keep in mind that the risk for schizophrenia in the general population is less than 1%. Family studies show that the risk for schizophrenia increases with the strength of kinship. This is illustrated in the figure on the left of this slide from the Kring et al. Text, with monozygotic twins exhibiting the highest risk. Note, however, that the risk for monozygotic twins is not 100%, indicating that schizophrenia cannot be accounted for by genetic transmission alone. Negative symptoms may have a stronger genetic component. Family studies suggest that the etiology of positive and negative symptoms may be different. In one family study, people with negative symptoms tended to have a history of pregnancy and birth complications and a failure to show electrodermal responses to simple stimuli. People with positive symptoms had a history of family instability, such as separation from parents and placement in foster homes or institutions for periods of time. Molecular genetic studies, looking at the association between how often a particular gene or genes and a particular trait or behavior co-occur, have found support for 4 candidate genes in the etiology of schizophrenia. Genome-wide association studies indicate that mutations or random changes in genes may also play a role in the etiology of schizophrenia. Remember that at a molecular level, genes impact the production and function of neurotransmitters, which impact brain and behavior. The first neurotransmitter to receive substantial attention in the etiology of schizophrenia was dopamine. Dopamine theory posits that schizophrenia is related to excess activity of the neurotransmitter dopamine. Support for this theory came from the fact that drugs which were effective in the treatment of schizophrenia produce side effects resembling the symptoms of Parkinson's disease, which is known to be caused by low levels of dopamine. These drugs block postsynaptic dopamine receptors called D2 receptors, effectively reducing the levels of dopamine in a particular nerve tract of the brain. Other support for dopamine theory included the fact that people with amphetamine psychosis, resulting from increased levels of dopamine, exhibited symptoms similar to schizophrenia. Some research suggests that individuals with schizophrenia have an excess of dopamine receptors or that their dopamine receptors have increased sensitivity. An excess of dopamine receptors seems to be related mainly to positive symptoms. The excess dopamine activity thought to be related to schizophrenia is localized in the mesolimbic pathway, which is shown in the figure on the right of the slide, and therapeutic effects of antipsychotics on positive symptoms occur by blocking dopamine receptors in this pathway. The mesocortical pathway, also shown in the figure on the right of the slide, is another scene of dopamine activity and may contribute to the negative symptoms of schizophrenia. The figure on the left of this slide from the Kring et al. Text illustrates how dopamine may play a role in positive and negative symptoms of schizophrenia. The dopamine theory, however, is not a complete theory of schizophrenia. It takes several weeks for antipsychotics to lessen the positive symptoms of schizophrenia, even though they block dopamine receptors immediately. This indicates that the effect may be the result of the impact of this blockage on other brain areas and other neurotransmitters. Other neurotransmitters which are being examined for their potential role in the etiology of schizophrenia include serotonin, GABA, and glutamate. Because schizophrenia affects so many domains, thought, emotion, behavior, it is unlikely that any single type of brain abnormality can account for all of schizophrenia's symptoms. Among the most well-replicated findings of brain abnormalities in schizophrenia are enlargement of the ventricles, dysfunction in the prefrontal cortex, and dysfunction in the temporal cortex and surrounding brain regions. In studies of ventricle abnormalities, research suggests that the size of ventricles may increase over time, indicating that brain abnormalities in schizophrenia may progress or get worse over time. Enlarged ventricles are associated with impaired performance on neuropsychological tests, poor functioning prior to the onset of the disorder, and poor response to drug treatment. Enlarged ventricles are not specific to individuals with schizophrenia. They are also seen in people with bipolar disorder with psychotic features. The prefrontal cortex, also thought to be involved in schizophrenia, is known to play a role in behaviors such as speech, decision-making, emotion, and goal-directed behavior, which are disrupted by schizophrenia. MRI studies have shown reductions in gray matter in the prefrontal cortex of individuals with schizophrenia. Failure to show frontal lobe activation is related to the severity of negative symptoms of schizophrenia. Abnormalities of the temporal cortex, including areas such as the temporal gyrus, hippocampus, amygdala, and anterior cingulate, are also found in people with schizophrenia. Several different environmental factors have been studied as possible contributing factors to schizophrenia. These include brain damage during gestation or birth, which could contribute to some of the brain abnormalities we just reviewed. Maternal infections during pregnancy may also be related to the development of schizophrenia. Cannabis use amongst adolescents has also been investigated as a risk factor for schizophrenia. Cannabis use has been associated with the worsenings of symptoms in individuals with schizophrenia and with increased risk for developing schizophrenia. However, it is important to keep in mind that these findings are correlational, so causal interpretations cannot be made. Other studies suggest that the linkage between cannabis use and the risk of schizophrenia is found only among those who are genetically vulnerable to schizophrenia. People with schizophrenia do not appear to experience any more stress than individuals without schizophrenia, but they may be more sensitive to daily stressors. There is a sharp upturn in the presence of schizophrenia among those with the lowest socioeconomic status. There is also a higher prevalence of schizophrenia in urban areas. The hypothesis that the stressors of OSCS and urban living are associated with greater risk of schizophrenia is called the sociogenic hypothesis. This association could be present only for those who are predisposed to the disorder. Additionally, these types of stressors could have neurobiological effects which may contribute to the development of schizophrenia, such as maternal nutrition during pregnancy. The hypothesis of social selection posits that during the course of their developing illness, people drift into poorer neighborhoods, which is why greater prevalence rates are found in low-income urban areas. A few studies have suggested that families of people with schizophrenia communicate more vaguely with one another and have higher levels of conflict than families without schizophrenia. It is plausible, though, that the communications and conflict are a response to having a young family member with schizophrenia. Adoption studies suggest that the level of adjustment of the child may be involved in the risk of schizophrenia. High levels of expressed emotion, including critical comments, hostility, and over-involvement, have been found to be related to increased rates of relapse for individuals hospitalized for schizophrenia. It is not clear whether expressed emotion is causal or whether it is a reaction to the behavior of the individual with schizophrenia. Retrospective studies look at what people with schizophrenia were like before their symptoms began. Support has been found for an association between lower childhood IQ, more delinquent behaviors, and greater withdrawal and later development of schizophrenia. Boys later diagnosed with schizophrenia were rated by teachers as disagreeable, while girls were rated as passive. One study indicated that children who later developed schizophrenia showed poorer motor skills and more expression of negative emotion than siblings who did not develop schizophrenia. Prospective studies have identified childhood characteristics that were associated with the development of schizophrenia in later adulthood. One study found that lower scores on IQ tests in childhood predicted the onset of schizophrenia in young adulthood, even after controlling for socioeconomic status. Treatment for schizophrenia usually involves a combination of short-term hospital stays during the acute phases of illness, medication, and psychosocial treatment. In the 1950s, several medications collectively referred to as antipsychotic drugs emerged. These drugs were also referred to as neuroleptics, as they produced side effects similar to the symptoms of neurological disease. For the first time, many people with schizophrenia did not need to be hospitalized for long periods of time and could return home with a prescription. These first-generation antipsychotic drugs included thorazine and haloperidol, also known as Haldol. These drugs were effective for reducing positive symptoms, but did not have an impact on negative symptoms. About 30% of people with schizophrenia do not respond favorably to the first-generation antipsychotics, and about half of individuals who take one of these medications quit after 1 year, and up to 3/4 quit after 2 years due to the terrible side effects. Commonly reported side effects of all antipsychotics include sedation, dizziness, blurred vision, restlessness, and sexual dysfunction. There are also some additional exceptionally disturbing side effects called extrapyramidal side effects. These side effects resemble the symptoms of Parkinson's disease. Second-generation antipsychotics included clozapine, trade name Clozaril. It was initially found that this drug worked better and had fewer side effects. However, later research found that it can lower the immune system, produce seizures, and produce other side effects such as dizziness, fatigue, drooling, and weight gain. Other second-generation antipsychotics developed after clozapine include Zyprexa and Risperdal. More work is needed to find more effective medical regimens to treat schizophrenia with fewer side effects. Research suggests that a combination of medication and psychosocial treatments works best for treating schizophrenia. Psychosocial treatments include social skills training, family therapies, cognitive behavior therapies, cognitive remediation therapies, psychoeducation, case management, and residential treatment. Social skills training is designed to teach individuals with schizophrenia how to successfully manage a wide variety of interpersonal situations. Many people who are hospitalized with schizophrenia go home to their families. As discussed earlier, family factors may be associated with relapse. Family therapy teaches families about schizophrenia, gives them information about antipsychotic medication, encourages family members to avoid and reduce blame, builds family communication skills, expands the family's social network, and builds hope. Cognitive behavior therapies such as CBT have been shown effective in combination with medication in reducing hallucinations and delusions. They have also been shown to impact negative symptoms, mood, and general life functioning. Stress management training was also found to be effective in reducing stress among people with schizophrenia. Cognitive remediation therapies aim to improve cognitive functioning among individuals with schizophrenia. Psychoeducation is an approach that seeks to educate individuals with schizophrenia about their disorder, expected time course of symptoms, biological and psychological treatment of symptoms, and treatment strategies. This treatment approach has been found effective in combination with medication at reducing relapse and preventing rehospitalization due to medication noncompliance. Case management models such as assertive community treatment and intensive case management have also been used with individuals with schizophrenia. These approaches seem to be superior in reducing time spent in the hospital, improving housing stability, and ameliorating symptoms. However, positive effects have not been shown in other domains, such as improvement in social functioning. Residential treatment homes are sometimes good alternatives for people who do not need to be in the hospital, but are not quite well enough to live on their own or with their family.